Plantar fasciopathy. The name plantar fasciopathy is interchangeable with plantar fasciitis and plantar fasciosis. This condition is often misreferred to as a heel spur. How common is plantar fasciopathy? It's the most common overuse condition treated by podiatrists. Exact figures are difficult to confirm, but it's reported that 10% of the population are affected at some point in their lives. Those with high activity levels, the prevalence is up to 22%. It will typically present with sharp discomfort under the heel or the arch of the foot after periods of rest, for example the first few steps in the morning. Movement and use of the affected foot will reduce the symptoms as it warms up, but prolonged standing and activity will generally cause the pain to return again. The severity of symptoms can range from mild to intense and significantly impact quality of life. The plantar fascia is an aponeurosis, which is effectively just a flattened tendon. It originates from the medial tubercle of the calcaneus under the heel. At the origin, the plantar fascia is between 2 and 4 mils thick. It runs the length of the undersurface of the foot, thinning and splitting into 5 segments as it progresses towards its insertion under the toes. The plantar fascia has a strong central cord with thinner, medial, and lateral components. It acts as an origin point for the abductor hallucis muscle, the flexor digitorum brevis muscle, and the abductor digiti minimi muscle, all which are key structures for maintaining the foot's arch. There's also a close functional relationship with the calf muscle and the Achilles tendon. All of these, if tight, can lead to loading and damage of the plantar fascia. Functional role. The plantar fascia is a connective tissue, primarily responsible for the transmission of forces between the heel and the forefoot. You can see when the foot strikes the ground, it resists and slows arch collapse, helping to maintain foot posture. Looking closer, you see how this allows the foot to act as a shock absorber when the plantar fascia stretches. The plantar fascia consists of 30% collagen, which provides its strength, 2% elastin, which helps keep it elastic, all embedded in an extracellular matrix comprised of water and tenocytes, making up the remaining 68%. The tenocytes are responsible for the repair and maintenance of collagen after it is damaged from day-to-day use. Individual collagen strands are packed into groups called fibers. Each group of fibers is covered in a sheath. Many fibers will then form a bundle, and the bundles are aligned in an orderly fashion. The collagen is densely packed and aligned in the direction of which force is being transmitted long ways in the foot. The plantar fascia has a low blood supply at the base of the heel. This makes it slow to repair and leaves it susceptible to overuse pathology. In your pathology, the damage occurs on this micro scale every day, over and over again, frequent and repeated micro tears to those collagen fibers. A failed and slow healing response leads to a thickened, tangled, discontinuous and weakened point in the plantar fascia collagen fibers. As a result, the normal presentation, typically a 2 to 4 mil thick plantar fascia, becomes thickened and painful at the insertion at the base of the heel. Overuse pathology and how do they occur? Daily use and demands on the plantar fascia cause microtrauma to the collagen fibers. This process only becomes problematic when the amount of damage is greater than the level of repair. With each day more damage than repair occurring, the damage accumulates and the collagen fibers within the plantar fascia begin to degenerate. And finally, producing plantar fasciopathy. Once there is damage to the collagen, the tenocytes responsible for its maintenance and repair are also damaged and degenerated. This will further impair the body's ability to repair the collagen, compounding the pathology and perpetuating a chronic overuse injury.